Okay, well, we're going to go ahead and get started. Welcome everyone to our third session of the webinar series, USC Otolaryngology, Ask the Expert. The series is sponsored by the Caruso Department of Otolaryngology, Head and Neck Surgery at the Keck School of Medicine of the University of Southern California. The goal of the series is to have experts from various fields that treat disorders of the head and neck region present relative topics and answer any questions you may have. We hope to educate you and stimulate thoughtful questions that will help you better understand some of the conditions we treat. It is not intended as medical advice, nor to take the place of seeking medical care, but is as simply an educational experience. Today's discussion is titled A Multidisciplinary Team Approach to Thyroid Nodules and Cancer. Our speakers are Dr. Daniel Kwon and Dr. Trevor Angell. Dr. Daniel Kwon is an assistant professor in the Caruso Department of Otolaryngology, Head and Neck Surgery, and director of Head and Neck Endocrine Surgery. He specializes in thyroid and parathyroid surgery. Dr. Trevor Angell is an assistant professor in the Department of Medicine's Division of Endocrinology, Diabetes, and Metabolism. And his clinical and research interests are related to the diagnosis and treatment of thyroid disease. So we welcome you and the speakers to this webinar. We will try to answer your questions at the end of the presentations. If you have questions, please use the chat function down at the bottom of your screen. We will try to get to as many questions as possible in the time permitted. Without further ado, I will hand it over to our esteemed speakers.
Thank you for that introduction, Dr. Markarian. And so today, we wanted to talk to you guys about how we as a team approach thyroid nodules and thyroid cancer, share, why we do the things that we do, what choices there are for patients, and how the team approach really plays a role. So just a quick outline of what we'll discuss. We'll talk about the background information and sort of the backdrop in what informs what we do, the updates and advances in how we work up and evaluate thyroid nodules, the advances and updates in how we treat thyroid nodules and cancer, and how our whole team approach helps optimize patient care. And then at the end, we'll take your questions. And so just to begin, this may be somewhat elementary for some of the folks out there, but the thyroid gland is a butterfly-shaped gland in the front of the neck. It has two lobes, the right and the left, and it's connected by a small piece called the isthmus. And this gland produces thyroid hormone, which is really essential to life. And most people know it as, sort of driving our metabolism, but it plays an integral role in growth and development in utero and in children. And it sort of has a role in almost all our kind of bodily functions, such as heart rate, temperature, our gut, things like that. And so what are thyroid nodules? So thyroid nodules are essentially, discrete lesions or areas that are distinct from the rest of the gland. Most commonly, we're talking about, an imaging or ultrasound, but it can be clinically if we feel what we call a bump. And it's not always a tumor. And so sometimes it can be a cyst, a fluid-filled cyst. It can be a hyperfunctioning area of the thyroid gland called a toxic or hot nodule. And sometimes it's a benign growth like an adenoma. But of course, most of the time when we're thinking about thyroid nodules, we're thinking about cancer and is it cancer? When we talk about thyroid cancer, almost always the term, thyroid cancer is almost always synonymous with well-differentiated thyroid cancer or papillary or follicular thyroid carcinoma. And so this constitutes about 90% of all thyroid cancers. Luckily, these are the ones that kind of do the best, are the best treated. Other types of cancer include medullary thyroid carcinoma, which is oftentimes hereditary. And then thankfully, the most rare form is anaplastic thyroid cancer, which can be quite aggressive.
Great. So first, I want to say just welcome to everybody, and I'm very excited to be able to come share the education and outreach with the greater community with you all. So continuing on the background of this topic, when we talk about thyroid cancers, something we want to recognize is that thyroid cancer is among the fastest growing cancer types. We see here at the top for both men and women, that percent change is growing and outpacing other forms of cancer. And when it comes to the aggressiveness of cancer, how much we worry, age is an important element. And so older individuals, we may be more concerned about. And then like other cancers, we think about stage of the cancer as being an important factor. One back. So I wanted just to show this and explain it for a moment. This is a colorful figure from our recent publication earlier this year. And when it comes to stage, on the left-hand side is our older staging system, which was the 7th edition. And on the right-hand side is the 8th edition. And all those what those flowing lines show is that when we adopted the current staging system, we pushed a lot of people into that green stage 1. And what that shows is that really a lot of thyroid cancer is low risk, and we don't need to be as concerned about it. And the ones that we left in higher stages, that orange to purple, those people we want to identify as being at higher risk from thyroid cancer. And so on the right-hand side, thyroid cancer staging is unique, that age is a factor. So on the top, you see patients less than 55, either they're stage 1 or stage 2, and the prognosis at 10 years is very good. The survival is 85% or better. But in patients who are older than 55, the staging goes up, stage 1, stage 2, stage 3, stage 4, based on how aggressive cancer we find. And that 10-year survival is dropping. And so we know that there are certainly patients who are at higher risk for having serious thyroid cancer that we need to treat well.
So when we put those two things together, we know that thyroid cancer is, on the rise in terms of diagnosis. But when we look at folks who are suffering or dying from thyroid cancer, it really has remained flat over the years, as you can see here. So obviously, this has led us as a field to wonder, well, are we simply overdiagnosing cancers that may not be clinically relevant or, practically dangerous to patients? And so some of the theories are, well, we're using imaging a lot more than we used to in the past. People are getting a lot more ultrasound, CT scans than previously. In general, people are, have better access to healthcare. When we look, a few decades back, the amount of insured patients is much higher than it was in the past. And so, is this simply a matter of diagnosing more of the cancers that are out there, perhaps the ones that are very early stage? And so in a recent study, this was actually supported in that a lot of the rise here in the upper left graphs we see are in the small nodules, so under 1 centimeter or 1 to 3 centimeters. But this study also showed that we're seeing rises in larger, more aggressive cancers, 4 centimeters or above. And they also found increases in underserved populations, so populations that that aren't seeing their primary care doctor every 6 months. And so this is evidence to suggest that we are seeing a true increase in the rates of thyroid cancer. And along with this increase, we're seeing a great increase in thyroid surgery. And so, compared to 1 or 2 decades ago, there's just a lot more thyroid-related surgeries going on. And why this is relevant is because actually a lot of this surgery is being done for, suspicious nodules or indeterminate nodules, and many of them are not cancerous actually. This matters because, even in the best of hands, over a large population, thyroid surgery has risks. And so you're subjecting many more people to surgical risks. Of course, there are things like long-term effects, like having to take thyroid hormone replacement for the rest of your life if in cases of total thyroidectomy. And of course, there's just the socioeconomic burden of, time off of work, the costs of all this medical treatment that people have to bear. Another factor is, while, thyroid surgery is just a small piece of the pie, year over year, as a society, we're spending much more money in terms of healthcare. And so, we actually, a chunk of this is things like thyroid surgery, which can be costly, when we add up all the numbers. And so, how does this inform, how we approach the workup?
Yeah, thank you, Dan. That summary was excellent. To me, it really, all of that really speaks to needing to assess each patient individually and sort of see what factors are important in each individual case to kind of create the best treatment between, potentially over-treating and not wanting to not do enough. And so that's really where we get into how do we go about evaluating all of this. And what is up here is a little bit of an older schematic. And the first reason is we'll go over that some of it hasn't changed on the top part, and then we'll see how the part on the bottom, has evolved. So when a person has a thyroid nodule, we start with the investigation. And when we say thyroid nodule, sometimes there might be something felt in the neck, or there might have been a CT scan or an MRI that mentions a nodule. But we really want that ultrasound study of the thyroid as our best test to have a detailed understanding of a nodule, that we know it is that discrete thing in the thyroid that Dr. Kwon first described. So when we have that in a patient, we want to look at the blood tests, which is the TSH, or the thyroid stimulating hormone. Because when you look to the right, if that is low, that suggests that the patient may have hyperthyroidism, or too much thyroid hormone. And why that's important is because if the cause of that is the nodule, that hot nodule that he talked about, those don't require a biopsy. We investigate those differently. So they shoot off onto the side there. But for people who have a normal blood test for TSH, meaning that that their thyroid is normal, or even a high TSH, which would indicate hypothyroidism, as long as it's not thyroid hormone excess, we keep going down because that nodule still might represent thyroid cancer. And so the ultrasound guided biopsy is typically what we would perform next. And we're down at that bottom part, and it's fairly straightforward. On the right, if the result comes back that it was non-diagnostic, you frown and say, we have to do it again. We didn't quite get what we needed. Fortunately, the majority of biopsies that get done end up being benign, and those can be monitored without surgery or other intervention. And then the two on the left, if there was anything abnormal, anything suspicious, where the risk of cancer is there and surgery is performed to take it out. Okay, so let's take that bottom part and see kind of what it's like now. Oh my goodness, this is more complicated than anyone wants to have to understand. And I'm not going to go through all of this. This is just to demonstrate that how we approach these has become significantly more complex and detailed. But that's a good thing, because we can get much more specific on what individual patients need as far as their evaluation goes. And so it breaks down into two parts, the ultrasound part and the biopsy part, and we're going to go through each of those. So when we talk about doing an ultrasound and looking at a nodule, again, we want to get specific about what this nodule looks like, because it's going to tell us how concerned we should be about the possibility of cancer. So this figure is from the American Thyroid Association guidelines that were released in 2016. And they give us an atlas of different images that represent typical nodules and what the risk of malignancy is. So if we start at the bottom, that black, little ball is a cyst, and there's essentially no risk of cancer in those, fluid filled. Above that are things we consider mostly cystic or like sponges. Above that, more solid things. Above that, solid things that appear darker on ultrasound. And at the highest point, those nodules that have really worrisome features, little speckles of calcium, irregular borders, or even lymph nodes in the neck that look like metastases. So we can gauge our decision to perform a biopsy and evaluate further based on this ultrasound risk. This is another example, separate from the American Thyroid Association, from the American College of Radiology. That was from 2017. And Dr. Grant, who has long been here at Keck Medicine, performing ultrasounds and biopsies in our radiology department, was a significant part of this. And it looks at things a little bit differently, but ultimately has a fundamental similarity. Look at the nodules and determine how suspicious it is and when evaluation needs to be done. So doing a biopsy is fortunately a safe and well-tolerated procedure. Certainly, it's a sensitive area of the neck, and there can be discomfort, but it's something that can be done in the office under a local anesthetic, with really no precautions or restrictions before or after the procedure is performed. And as I mentioned, the majority of nodules that we do perform a biopsy on end up coming back benign. And then another percentage come back as positive for cancer. And we consider either one of those to be definitive. We know what's going on. Unfortunately, there will be a subset that come back a little bit with less certainty. And so what we're going to look at here is just all the biopsy results that we can get in this table. Okay, so at the top, I mentioned that non-diagnostic category, and this next one down is the benign category. And when we talk about these things, we're talking about what a pathologist can see with their eyes. So over on the left-hand side, there's just examples of benign thyroid biopsies. Those are nice, pretty, normal-looking thyroid cells. And then on the converse side, the definitive result of having a suspicious or a cancerous biopsy. So on the right-hand side, these are the things we might see in a specimen that we would call positive for cancer. Unfortunately, looking with the eyes, we can see a lot of things that look in between these two, where with the naked eye, we see features that are worrisome but not conclusive. And so between these two red boxes are what we call the indeterminate results, atypical and follicular neoplasm. And we have a question mark above our heads. And for a long time, there was uncertainty about exactly what to do. There's still a need to perform a detailed analysis. But what I want to talk about is new molecular testing that helps us look further into these and be able to tell what's going on. So these are just the examples of the commercially available diagnostic tests for indeterminate biopsy thyroid nodules. And these are the ones that are out on the market, all three of them. What is different is that instead of looking with the naked eye, we are talking about taking those cells and grinding them up and looking at the genetic interworkings, the DNA and the RNA, and seeing if there are things about it that look like cancer, like mutations, or nothing at all interesting going on that look like benign findings. And what these tests try to do, you could do two things with a test. You could try and rule out cancer, say, I know for sure you don't have it. Or you could try and rule in cancer, say, I did this test and I know for sure you do have it. And for many reasons, just having to do with how complex this is, the way these tests work is to try and say, okay, we're almost sure you don't have cancer. So that means in this box, we're talking about, we want a test that's negative, and when the test is negative, it truly is telling us that the thing is benign. And that's what all of these tests do very well. So let's just look at this a little bit differently to help us understand. Here are all the people with thyroid nodules. And these ones in blue are the ones who are going to have an indeterminate biopsy result, that one in the middle with the question mark bubble above our heads. So out of those people with the indeterminate cytology, these two in orange are the ones that are going to have cancer. And the ones in blue are going to end up having something benign. And that's an important thing to remember, that most of the people with indeterminate results don't have cancer. So if we do a molecular test and that test is negative, that tells us out of every 100 people we do that test on, only a small percentage, 5% or less, would actually have cancer. We could say with confidence that almost all of those people are benign. But if we do that same test and it is positive, we can now say out of every 100 people that we get a positive test on, more than half of them are going to have a cancer. And so these results now have given us two very distinct groups. We do this test and it's negative, we favor monitoring people because their risk is low. If we do the test and it's positive, we really want people to go have surgery and take this out because the risk of having a cancer now is significantly higher. One thing we want to keep in mind is that how likely cancer is before we do this test tells us something about our test results. And this is a very, very, very math-looking chart up here. But essentially what it tells us is if everything says this is benign, go back to that ultrasound, where the features look like it's really low risk and many other things. If we do the test, regardless of the result, it's likely to be benign because it was so low risk to start with. But if something is very worrisome to start with, all those features on the ultrasound are suspicious and the person says it's growing very quickly and other things, the chance that it's a cancer before we start is very high. So in that case, even with a benign result, we might not be reassured. There might be such a high risk that you're one of those few people that we really need to keep in mind. What's our starting place with this individual when we take everybody, as a personal case? And so this is also something we keep in mind in our modern testing. So I think that really leads to how it sort of transitions to how do we apply treatment. We've talked about when you have a nodule, how do we investigate it to tell if it's benign or cancer, and how do we tell even further in those difficult cases. But now we've come to the point where we're need to perform surgery. What are the options there, and what are the best standards?
And so when we talk about treatment, the trend of kind of the state-of-the-art treatment is sort of mirrors how we are working up these nodules, meaning it's not just we see something there, we're going to throw the kitchen sink at it. Similar to how we're doing the workup and where we're becoming more refined and trying to parse out the people that we really should be concerned about and the people that we really don't need to be concerned about. Similarly, in terms of treatment, we're going from a very aggressive, full treatment to a more refined, more selective, more refined type treatment. And that's sort of how the pendulum is swinging in terms of thyroid surgery. And so similar to, what Dr. Angell was talking about, and in treatment, it's not just a one size fits all for anyone with a thyroid nodule that looks funny or has some atypical cells. Instead, now we can kind of individualize the treatment and figure out for each type of person or type of nodule, considering not just what the nodule is telling us or what the nodule is looking like, the patient factors such as the age of the patient, the preferences of the patient, comorbidities, other medical problems, and we're sort of able to have a more tailored approach. And the treatment is really more focused on outcomes, because if we were to rewind all the way back to some of our first slides, we can see that most people do quite well in terms of the cancer. Most people continue living their lives, and so we tailor our priorities to optimizing how patients do long term. One such example of this is kind of this thyroid radiofrequency ablation. So, this is a technology that's not new. It's been around for a few decades. It's used in other areas of the body, but recently it's become FDA approved as a non-surgical way to treat some of these nodules. And so for nodules that we know are benign or are making too much hormone or are causing a cosmetic defect, this is actually a non-surgical way to treat nodules without having to either have a black and white approach saying, oh, we can't do surgery, or yes, we're gonna, take out your entire gland. And so, this actually is done quite similarly to a ultrasound guided biopsy, where it's done with a little bit larger needle. And this can be done either awake in the clinic or in the operating room, like what you see here. And so, this is still quite early, but, I think this is going to be something that we see more of in the future. Right now, the reason why it's not more popular is because there are no clear guidelines. And this is a treatment that's commonly used in Europe and Asia, but in the United States, it's a bit slow to take off. And a big part of that is the cost. And so a lot of insurance companies don't know what to do with this procedure. And so typically it comes with a fairly significant out-of-pocket costs. And so on the graph here on the right, you can see that although, this is a procedure that's much shorter, much less morbid in many cases, the cost is actually similar. And of course, like any treatment, it's not this magical risk-free treatment. There are similar risks to thyroid surgery, but like I said, it's just another option kind of in our toolbox that we have to offer patients. Another factor in terms of the treatment of thyroid nodules and cancer is just that we've gotten better at the surgery. Just the run-of-the-mill neck incision, which constitutes probably over 90% of thyroid surgeries. We've transitioned to doing these outpatient. I trained at a institution that was one of the early adopters, and with our experience, we were able to demonstrate that this was absolutely safe for most people and selected patients. And nowadays, we are even seeing this done in the pediatric or other high-risk populations. And so we've just gotten better at more conventional thyroid surgery. One thing the field is also doing is it's shifting from kind of occasional thyroid surgeons to higher volume thyroid surgeons. So a lot of data has come out showing that actually most of the thyroid surgeries out there are being done by folks who do these once in a while. In fact, only about 1% of all surgeons are kind of high volume thyroid surgeons, which means typically at least 100 cases per year. And this actually holds through. It's not just, we're taking on the toughest cases. Some of these, low volume surgeons also do kind of these more risky surgeries and more difficult surgeries. And so we've sort of started working towards kind of shunting difficult patients to higher volume surgeons that are associated with better outcomes And this is basically shown out in the data, where when we compare low volume, which is 10 or less per year, to intermediate volume, which is up to 100 per year, and high volume over 100%, over 100 surgeries per year, we actually see meaningful drops in terms of, voice box injury, calcium gland injury, and it's also associated with quicker surgeries and cheaper surgeries. And so this has kind of led to the establishment of centers of excellence, kind of like how we have here. As you can imagine, it's tough for, one small practice or a small hospital to really have enough cases to have one surgeon really be an expert at it. But, at institutions like Keck, where we have a much larger department, where we sort of funnel these cases to a few specialists who become high volume surgeons, that really increases the quality of surgery, and it increases, the training of the next generation of surgeons. I was lucky to train in centers that were high volume. And so, by the time I graduated out of my training, I'd already seen hundreds of these surgeries. In addition to just, improving the technique of conventional thyroid surgery, we're developing new ways of new options, such as scarless, minimally invasive type thyroidectomies. We have endoscopic assisted thyroidectomies, and these are just kind of added tools in our toolbox to be able to offer patients. Of course, this is relatively niche, but it's still something that you can generally have offered at kind of these large centers. This is a photo of me here. I think this is a couple years ago, where we're doing a video assisted thyroidectomy, where we still make an incision, but it's much smaller than a conventional incision. And then we're able to use a kind of a high definition camera to see very up close and very refined on what we're doing. But there are times where surgery isn't the right thing to do, even in terms of thyroid cancer. And so for selected patients and selected cancers, there is something called active surveillance that Dr. Angell will talk more about.
Yeah, thank you. It was great to hear about all those surgical advances. But now I'm going to run the gamut a little bit on what's going on non-surgically in thyroid cancer, and starting off talking about not performing surgery for thyroid cancer. Many people may be surprised at. Historically, it would be blasphemy to say such a thing, but it's a concept that people may actually be familiar with if you think about prostate cancer, for example, where there's some familiarity with observing things that appear to be low risk, knowing that many men may never suffer from it throughout their entire life. And in fact, we have known that studies do show that people who have died after long, healthy lives we can find that small thyroid cancers were present in the thyroid gland after death. And so, this idea was taken up by excellent doctors in Japan, and we owe them greatly for undertaking this, that they started to observe less than 1 centimeter papillary thyroid cancers, what we call microcarcinomas, without surgery. And we now have evidence from long periods of time, 10 to 15 years, about what happened to these individuals. So it's worth, I think, showing just a little bit that they had a group of people on the left who did go straight to surgery and have this small tumor removed, and then a group who were monitored, who had active surveillance in which an ultrasound was performed every 6 months and ultimately once a year. And their follow-up could be anywhere from 1 up to 10 years. And what they were looking for were Did it grow? Did anything appear to be getting worse? So what was found was that starting on the right, 92% just remained under observation. There was a group who ultimately did go to surgery, but it wasn't because anything had changed. Maybe the person's mind had changed. And then a group of 2.3% who went to surgery because the cancer had actually grown a little bit. And then finally, only 0.5% of people who developed a new lymph node metastasis during that time who went to surgery. And so looking at the yellow ovals now, the people who went to surgery because there was some progression, something that caused them to worry more, were compared to the people who right up front went and had surgery. And when they looked at how the ultimate outcome, was their cancer worse? Did they have recurrence? Did they need more treatment? Any of that? These were no different. So this delay while people were being observed in those small percentage who ultimately needed to have treatment, they did not appear to be any worse off than the people who had surgery right away. So this has really led to, greater acceptance of the possibility of active surveillance. Certainly somewhat greater adoption, although, it's still not utilized that frequently. And that's likely, because doctors may not be comfortable with it if they aren't familiar with it. Patients may not fully understand the idea or why it might be good. But we have learned a lot from the continued use. And one thing that seems to be a best practice is you want these three parts of the Venn diagram to be aligned, to have an ideal patient. So the first would be the right tumor. Not every thyroid cancer should be considered a good candidate for active surveillance. Certainly size is one factor, but also location. If the tumor is close to something that might be easily affected, like the nerve for the voice or a blood vessel, that might not be a good choice for observation. The second would be the right patient. And for this, it's often talked about who are the minimalists and who are the maximalists. There are people who are inclined, they would rather not do anything, that the idea appeals to them. And there are those people who clearly are, want it to come out, whatever the most aggressive option is, that's what they would prefer. These are not correct or incorrect positions. These are patient preferences, and that's very important. And the last part is the right team, really having a group to do the ultrasound, to do the surgery, to perform the follow-up, who are comfortable and ready to work with the patients in a consistent way. So the next sort of non-surgical piece of thyroid cancer treatment that I want to touch on is the use of radioactive iodine. And this just, I think importantly, is to recognize that today this is not standard for all patients. We do look at patients who have had thyroid cancer after surgery and what their cancer is like to help us determine who is going to benefit from radioactive iodine. So we have low risk cases, and these are part of the American Thyroid Association's definition. Cancers that were in the thyroid and did not spread anywhere outside the thyroid. And these patients, by and large, radioactive iodine is not recommended. There are people who we consider at somewhat higher risk. Maybe they have some variation that is more aggressive, or they have invasion, or they have lymph node metastases that increase the risk of recurrence, where we consider radioactive iodine more strongly, although opinions may vary. And then those people who are at higher risk, whose features of thyroid cancer even if it was removed, look aggressive, or in cases where the entire cancer was unable to be removed. And those are the ones clearly where we do use radioactive iodine. So just to summarize that, avoiding it in low risk patients, favoring it in patients who seem to have a higher risk of cancer spread or coming back, and definitely used for people who have had metastases to other parts of the body. So the last part, moving through from the non-aggressive ones we might watch to the medium aggressive ones that we might, do radioactive iodine after surgery, to really the most aggressive cases. So what we're talking about here are cases that we call progressive radioiodine refractory and metastatic thyroid cancers. So progressive meaning that there is clear growth or spread that we can observe, and radioiodine refractory meaning the use of radioactive iodine has been ineffective. So one huge advance came several years ago with the approval of lenvatinib, which is a systemic therapy like chemotherapy called a tyrosine kinase inhibitor. And in this study, it really showed that it slowed the progression of thyroid cancer. So the blue line is showing that they stayed free of progression compared to the placebo, in which the line going down means that more of them were progressing as time went on. And this was a really big deal as an effective treatment for these cancers. What's even sort of more novel to address these cases further is to find targets in the mutations, the things that make these cancers go, that we can apply a drug and find a drug that will block the specific thing that's happening in that cancer and slow their growth. Okay, so we know that there are follicular cell cancers that make papillary thyroid cancer, that is the most common. And on the other side, I'll just mention, we know that a different cell in the thyroid makes medullary thyroid cancer. Okay, and so this is the part where I get to say a bunch of words that look like a bunch of nonsense letters strung together. But these are the drugs that target parts of these cancers that are very specific and keep them from growing with fewer side effects. So inhibitors of the RET, selpercatinib and pralsetinib, inhibitors of the BRAF mutant protein, drabafinib, and trametinib is a bit similar, or vemurafenib. And then fusions like oretrectinib, which inhibits the NTRK. Now these come up infrequently, but for people who have serious cancers who don't respond to treatment, we need to be looking for these now and trying to apply these treatments when we can find a specific target. The last thing I'll mention is just to be very forward-looking in where cancer treatment is going in general. So one clear advancement within the last 10 years has been immunotherapy, particularly what are called immune checkpoint inhibitors. So the immune system has the ability to detect and remove cancer cells. And this ability is dampened by cancer. And we know that's part of why cancers exist and grow. And through the use of medications, drugs that are against the CTLA-4 molecule or the PD-1 molecule, we can reactivate the immune system's inherent ability to fight cancer cells. And these are drugs that now exist in a variety of cancers as approved treatments and are in trials to be used in thyroid cancers that are very aggressive as well. So it continues to be something very exciting in the field of oncology.
Thank you, Trevor, for that good summary. I think probably one of the most impressive things is how you said all the names of the drugs accurately. So that was probably the thing I was most impressed with. But when we talk about our team and how we all work together, I think we've sort of summarized why kind of finding the right stakeholders to work together to kind of find solutions to individual problems is important. So our team is sort of a collaborative effort from different folks within our tech medicine team. But in general, we're a high volume thyroid center, meaning we see many hundreds of these patients per year. We do about 400 to 500 of these thyroid surgeries per year. These are all specialists and who focus on this type of care. Recently, we've trying to streamline our care. We've hired patient navigators to try to streamline shared patients between the different services. We have a thyroid cancer specific tumor board to bring in folks from the Norris Cancer Center, the endocrinologist, surgeons to all kind of work together. And of course, we have different clinical trials that are ongoing available for patients. And so, the stakeholders are the endocrinologist, Dr. Angell leading them. We have the surgeons from the Head and Neck Center. We have our Norris Cancer Center. These are the folks that we work commonly with. And one of the main focus I wanted to end on was our focus on kind of whole person support. And so we have a big emphasis on patient rehabilitation. We have our voice center. We have Dr. Villegas, who focuses on swallowing and the patient support services. And we have cancer survivorship is something that's oftentimes ignored. People refer to thyroid cancer as the quote unquote good cancer. But we've done studies that show that actually in terms of quality of life, lots of other dimensions of quality of life, such as social, psychological, spiritual, this is actually quite similar to other kind of more aggressive or cancers with worse prognosis. So these patients still deserve a lot of support and care. And so one of the kind of the biggest thyroid survivorship organization out there. We had a conference this past fall with Dr. Angell and I were both speakers for, and we have another conference coming up in Los Angeles, hopefully in person this coming fall as well. And so I think this is definitely something that should not be neglected for our patients as well.
Great. So, we're concluding there, and we hope to be able to answer questions. I think just to hit the bullet points on this, that this is a problem that is actually on the rise, and we need to do a good job with our selective workup to really make the treatment best that it can be, both with the diagnosis and the treatment options, and that we're learning continually that real specific and multidisciplinary teams are the way to get the best outcomes.
Okay, well, thank you so much, Dr. Kwon and Dr. Angell. We've gotten some good questions from the audience, and I just wanted to remind everyone, if you still have questions, you can type them into the chat function down below. But let's get started with the questions. The first one was really a question about thyroid disease and if there could be any association with the pituitary or the pancreas glands.
Sure. The answer to that question is certainly it depends. Pituitary disease is relatively uncommon, whereas problems with the thyroid itself are much more common in the population. So typically when we see abnormal thyroid tests or problems with the thyroid, we're not thinking that there's anything wrong with that part of the brain that does help control things. But we need to keep that in mind when we look at thyroid tests, because though it's rare, there would be certain markers that would suggest it as a possibility. I think, when we talk about the pancreas, diabetes is certainly a very common condition, but we shouldn't be, it's not commonly going to be, caused by thyroid problems or be the cause of thyroid problems.
Great. And one of our other participants asked, where's a good place to start? Should they see a otolaryngologist, head and neck surgeon, or an endocrinologist to begin with, their primary care physician?
Sure. So I think again, I would certainly welcome anyone who has a question about what's going on to help, provide information and advise things in the best way that I could. But I think when people come in to KEC, we do want to try and streamline them to the most appropriate location. For people who have already had a biopsy and they know they have a thyroid cancer, maybe it makes sense to go straight to the otolaryngologist who can perform the surgery in most cases. If you've gotten an MRI and it says maybe there's a nodule there, probably seeing the primary care doctor to get that initial ultrasound to even know what's going on makes the most sense. And when it comes to abnormalities of thyroid testing or thyroid nodules that haven't been evaluated yet, that's the endocrinologist is right in the middle there. And that probably makes the most sense.
Okay, great. Another question from one of our participants is, if you had a normal thyroid globulin level prior to surgery, how good of a marker will it be for recurrent disease after surgery?
Yeah, that's a great question, and a very nuanced one, really. By and large, our understanding comes from the days in which everyone got a total thyroidectomy and everyone got radioactive iodine ablation. And so it didn't matter too much what things were before surgery, because they were always going to be, if things were good, there was none left after the process. And now because we don't want to expose people to unnecessary risks, we do live in a world where we detect a tiny amount of thyroglobulin that's normal and not concerning. But the question is, well, what if there was none there to begin with? Is it then harder to detect? So I want to start by saying there's very little evidence in this area, but the concept is well taken, and we consider that when we look at someone's thyroglobulin over time. It does help to know how much there was to begin with, to look at trends, to look at changes, and determine the significance of them. I think it's an excellent question.
Great. Well, here's an interesting comment and question. From an attendee who said that they're very thankful and for the presentations. And the question is, are there any special projects you both are working on that we as patients can support with a donation? Or if so, how can we do so? And if so, how can we do so?
Yeah, well, that is a terrific question. And I know Dr. Kwon is trying to get his audio back, and hope he can hopefully add something. So there are several primary areas of interest that we have, and one of them clearly goes to what we've been talking about. Hopefully tell it is our passion to get at what is the best way to understand what patients have and how to treat them best. And so studies that look at when should people have biopsies or be followed? How do people, have the greatest satisfaction with their care? In these times, I know Dr. Kwon is actively investigating, does telehealth provide patients with the same level of confidence and quality as we did before the pandemic? And that's important to know, because for patients who live far away, if we can extend our reach through that way and still deliver the same outcomes, we want to be able to do that. We also have kind of real scientific studies related to grants where we assess the thyroid tissue and we look at those immunology cells and try and understand how to use those immunotherapies to improve cancer outcomes. So, those are ongoing projects. I know there are people here on this call that are affiliated that could help with answering the question how and when, and we would be incredibly grateful for that. But I think that's a sense of what we're doing.
Yeah. Well, yeah, thanks. Thank you, Dr. Angell. I know you're doing wonderful research here. And we have a question in regards to Hashimoto's and whether there's an increased risk of developing cancer after having it.
So for people who have Hashimoto's thyroiditis, the autoimmune condition, it is an open question whether or not they are at greater risk of thyroid cancer. That's another great question, and you're testing me with the controversies in the field. I think many would agree that there may in fact be some increased risk, but fortunately it also seems that there is a better outcome. Something about it is a less aggressive course. And so people who do have thyroid cancers in the setting of Hashimoto's appear to do better. So that is a mixed bit of solace for those patients, I understand. But that is a really a big area of interest.
Okay, great. Also, there's a question whether there is any association between benign thyroid nodules and eosinophilic esophagitis.
Not that I am aware of.
Okay. I don't know if I'm back online, but yeah.
Yes,
okay, great. Sorry about that. Yeah, no, I don't think so. I think they're sometimes related in terms of they can cause similar presentations and symptoms for throat discomfort, things like that, but not in the pathophysiology or development of those problems, no.
Okay. And then there was also a question about a correlation of diet to the rise of nodules and cancer.
So we don't have evidence that any particular diet would be a culprit in that, but thyroid cancer has been identified amongst the list of obesity-related cancers identified by the World Health Organization. So to the extent that we talk about our Western diet, perhaps, and increasing rates of obesity, that may be a risk factor.
Okay, great. One of the participants was asking about the dates for the thyroid conference. And then there was
June 5th.
June 5th.
Saturday, June 5th. We're still virtual this year.
Great.
And if you go to the USC CME website, you would be able to find it.
Yeah. There were also a couple of questions in regards to having this webinar sent to the participants, and just wanted to let everybody know that these webinars are recorded and then they're uploaded onto our website, and you should be receiving an email in a week or so with that link. So it will be available to you, and for all of the webinars.
You'll get to see me having technical difficulties, forever if you want.
Good. Well, I think we have time for maybe one or two more questions. There was a participant that had a chest CT with contrast that showed thyroid micronodules. And then the question was, is this something that needs to be further evaluated, and how does the CT compare to an ultrasound?
Yeah, that's a really common story that we hear. You get a scan in your chest or your shoulder for something, and they notice nodules. The next step is to get an ultrasound. So ultrasound is really the main tool that we use to image thyroid nodules, because these are nodules within a larger soft tissue gland. And so typically ultrasound, a high quality ultrasound, would be the next step. And it's generally superior than a CT scan in evaluating the quality of the nodule.
Okay. And great. And Dan, are you doing the thyroid ablations?
Yeah, and so we have a vendor and everything like that. It's just a matter of finding the right candidates. And like I sort of alluded to, the whole who's going to pay for it, unfortunately. That's typically the biggest barrier we have right now, and hopefully in the future, insurance companies will get on board.
Okay, that's about all the time that we have. So I just wanted to thank Dr. Kwon and Dr. Angell for their wonderful presentations. And I wanted to thank everybody for viewing and being here, allowing us to have this. And I just wanted to make an announcement that our next webinar series is going to be April 22nd, again at 12 p.m. And our presentation is going to be on skin cancers and sentinel lymph node biopsy by Dr. Mark Swanson and Dr. Jenny Hugh. Again, if there are any further questions or people wanted to make appointments, our phone number is listed above, and it's 323-442-5790. And finally, just thanks everybody. Take care.